May I now request Dr. Siabal Kar to kindly come and give his talk on left atrial appendage closure.
Right. There's a lot of interest in all the interventional cardiologists in our country now on this device. That's why we have wanted to have this live. And the idea why we selected you also is because whoever is pioneered and has done maximum cases, we wanted them to give talk. That's how Sushil, we're thankful to him for arranging him for this talk. Thank you.
Thank you, Srinivas. Thank you, all of you all, for allowing me to be here. Let me just... It's always a good thing to be in India. I always try to find an excuse to be here. So we're going to talk about left atrial appendage closure, the review of the evidence. And you already saw a case yesterday, even though it is not complete, but you did actually see the principles of the procedure. So I'm going to focus actually on that device. These are the common factors that we know about atrial appendage occlusion, that thrombus arising from the atrial appendage is the major cause of stroke in patients with AFib. And this is actually a fact. And percutaneous closure of the atrial appendage, rather than long-term anticoagulation, is an option to prevent stroke in atrial fibrillation patients. And there are certain studies which have been completed or are ongoing with different devices which are supporting this very important hypothesis. And so these are the devices that are available, either in clinical trials or actually clinically available. On the top is the Watchman device made by Atritech, now by Boston Scientific, the Watchman Generation 2 on the left side, and you can see over here on the right side is the Watchman 2, this second device, which is Generation 4. You can see it's rounded, and this is actually much safer. And then you have the Amplatzer cardiac plug, which is a shorter device, which makes it effective in broad, short appendages. And then you have the WaveCrest device, which is very early in its phase, very non-thrombogenic. So what I'm going to talk about is the Watchman atrial appendage closure device. You can see it's made of nitinol. There are barbs over there in the middle, which actually helps to hook and anchor on the appendage. And it's covered with a PET fabric, which is porous, allows contrast to go through, and later gets completely endothelized. The procedure is a transeptal procedure with a 12 French sheath advanced into the... why is it not playing? Well, it seems like the films that are going to play. So the device over here, you can see, is it comes in a delivery sheath. There are two delivery catheters, the 12 French single curve and the 12 French double curve. The double curve helps you to be coaxial with the appendage. The most important part of the procedure, as you saw yesterday, was to measure and understand the appendage in multiple views. And you can see over here, we've done 0, 90, 135, and 45. And I have to tell you one secret. Just focus on 0 and 135. If you understand these two views very well, then you'll actually know the maximum dimension. You measure from the circumflex across, that's the width, and this is the length. And you have to make sure that you choose that the length has to be at least the size of the breadth. So if the length is too short and the breadth is too large, the Watchman will not be able to be used. It's also important to recognize how many lobes you have and if there's evidence of thrombus, because if there's active thrombus, then you withhold the procedure at that time, wait, give patient Coumadin, wait for 3 months, and then bring the patient back into the procedure. And it's very important to see the two lobes, and this is the anterior lobe and this is the posterior lobe. And when you choose a device, you choose a device which is 20% larger. So you get devices ranging from 21 till 33. So in other words, just to give you an example, if you're measuring a device which is 20 millimeters, then you take a 24 millimeter device. If it's a 24, use a 27 device. So these are the 4 steps. You're advancing the pigtail into the appendage, very important step, and not a wire to prevent any tamponade. And you can see over here doing an angiogram, which tells you exactly where the view is. The next part, as you see, is the sheath, and you can see I'm delivering the device by gently retracting the sheath and allowing the appendage to open up. The third is actually seeing an angiogram, and you can see complete occlusion. Can you see that? Complete occlusion. And I actually want to play this again because this one actually shows the device and the tug test. You see I'm pulling the device. As you pull the device with contrast, the entire appendage as well as the device move together. And that shows you that it's safe. You see that? The whole appendage and the device is moving. That means it's stable. And then once you've reached that, then you release the device, and you can see it's completely shut off. So this is the right way to do it. Pigtail, append device, pull it in, do a tug test, and then release it. It's important to see some of the clinical updates stuff, but here's an example of a three-dimensional view of the appendage showing you the mouth of the appendage is not round but oval, and therefore you have to measure in all the dimensions. And here's an example over here of this, over here, exactly over there, right in the middle, and you can see it's completely shut the appendage off, and you can actually see that NFOS view. So the data for a clinical appendage comes from a series of clinical trials of over 173 patients which are actually in clinical trials. There is no other device with so much of clinical data in prospective randomized studies. I'm only going to focus on the first part, which is the pilot randomized studies in the US, and then a few words of the new study called PREVAIL. So the prospective randomized trial, PROTECT AF, was the first study to demonstrate whether actually appendage occlusion does work, because we had never proven that even with surgery. So you randomized 463 patients to closure of the L appendage versus 244 who were randomized to warfarin, and the primary composite endpoint was stroke, cardiovascular death, or systemic embolization. And there was also a safety endpoint to see hemorrhages, bleeding, embolization, surgery. And you can see over here, 85% of people came off Coumadin by 45 days, 6 months about 92%, 24 months 94%. So you said, what was the criteria to take them off Coumadin? The criteria was that at the end of 45 days, they actually had 45 days, 6 months, and 1 year, they had to have a gap less than 5 millimeters on either side of the device. There was no thrombus in the device. It was called a successful result. So we do it 45 days. We see there's no more gaps. You take them off Coumadin. You give them aspirin and Plavix for a few more months. You repeat the T at 6 months. If there's no further clots, no gaps, then they come off Plavix, then they're aspirin forever. You never come back on Coumadin again. And the last T is at 1 year. So you can see here 90% came off Coumadin by the end of 1 year. Now this is the data. This is the data of 1,500 patient years. 1,500, as you know, means 1,500 patients followed for 1 year, or 400 followed for 10 years. So you can see over here, the event rate in the Watchman device was 3%. In the control arm was slightly higher, 4.3%. The difference was not statistically superior, even though there was a 30% reduction of events, but it met the criteria for non-inferiority to Coumadin. All we wanted to show that we're non-inferior to Coumadin, and you can see over here, we met the criteria even though we were slightly better. But this has gone up to 5 years now. What his intention to treat, on the other hand, was the safety events, and this is important. And you can see over here, the safety events were higher in the Watchman group. So 5% versus 3.6%. It was not statistically significant, but it was different. And if you looked at the safety events, the main safety events were two. One is pericardial effusions and tamponades, an occasional periprocedural stroke, and later bleeding. And if you look at these events that we important events, this actually led to a problem, because people said, look, this is an issue that's a great procedure, but you could actually have a periprocedural stroke or a tamponade, then why even do this procedure? So this led us to, and this actually led to the FDA trying to withhold it for some time. But now I want to show you, so therefore this conclusion of the study was that left atrial appendage occlusion is non-inferior to long-term Coumadin as far as efficacy is concerned, but there were certain safety issues in the procedure which decreased over time, and this is what I'm going to show you. So we did a continuous access registry, and what we did is we removed all the sites which had done less than 15 cases, and we only allowed the sites which had done 15 cases, and there was 30 sites chosen, right? And they were allowed to register patients, and this is the paper that we published in Circulation early this year, which is actually a very important paper to show you the safety of this procedure over time. And what we did is we compared the results of the CAP registry versus the PROTECT AF trial. So this is the CAP registry. Look at what happens. As soon as you go, and there's the same number of patients, about 500 in same, 62 minutes versus 50, implantation success went up dramatically from 89% to 95%. That shows you learning curve. And the discontinuation of Coumadin is 95% of 45 days versus 86. All telling you that a lot of it's the same device, but what it is experience. So as you have more experience, you do the thing correctly. The next important part is the complication rate. I want you to watch this. If you see pericardial effusion in the beginning of the study was 5%. At the end of now, it's 2%. That means the issue of pericardial effusion has not gone away. It's still there. But here is the most dramatic thing, is strokes. Periprocedural strokes due to air embolism was 0.9% in the study. It's 0 in 500 patients. So this has nothing to do with the device, but it's completely related to the way you dealt with the sheath. So proving a point over here that the continuous access registry showed that actually if you do the procedure correctly, you could actually improve the success with the same device. So this is very important to collect data. But notwithstanding that fact, the FDA, when we went with this data and the original data, they understood the efficacy, but there were concerns about safety, and that is the reason why they actually asked us to repeat a second study of 400 patients, really a confirmatory study. And in this, patients with CHAD score of 2 will be included. In the initial study, CHAD score of 1 or more were only included, because people said, why do you include patients with CHAD score 1? Because they probably don't need Coumadin for CHAD score 1. So now it's going to be CHAD score of 2, and in CHAD score of 2 or more, or CHAD's VAS score of 2, 50 sites in the US, already 120 patients have been done. It's again same 2-to-1 randomization, same therapy, but the patients cannot be on dabigatran, they have to be on Coumadin versus the device, and it's the same device. So we hopefully the combination of the data of this study as well as the original PREVAIL and the CAP will probably summarize the fact that this procedure is effective, and this is actually a major challenge. And I personally think that in India, with such a large incidence of chronic AFib, now I wanted to tell you that all the cases that were done in the study were non-rheumatic mitral AFib, not in patients with mitral stenosis. So we don't know what this would happen if you take patients with mitral stenosis and AFib, would you get the same results. But personally, I feel that actually it will also work even in rheumatic. It won't go to 0, but it'll actually be also effective. So this is the regulatory approval. The FDA, the CE mark approval in 2005. FDA had a positive panel in April 2009, recommended a further study to confirm efficacy and demonstration in the previous studies. So the next device is the Amplatzer cardiac plug. And you can see this device was available CE mark on 2008. Now here's the hypocrisy of cardiology. Here you have a device with absolutely no data, which got a CE mark approval in 2008. And so the previous company did the right thing and had to suffer. And this one, they actually had no data. They had the device in, they stuck it into patients, and they got a CE mark approval. So I don't understand this, why you have double storage. But anyway, what you can see over here, this device actually is a very good device, but I'm not saying it's wrong. It is a good device. And now they have a US study starting with a pilot study just over, and now a full randomized study to prove that it actually is got the same effects as the other one. So the difference of this device is very different. You can see here it has two parts. It's got a lobe and it's got a disc. So the lobe actually anchors the device in the mouth of the appendage, and the extra disc shuts it off like a lid. So this device is actually quite effective in like the case from yesterday. Remember the case yesterday where it was a very broad appendage with two lobes and the device was sticking out. And probably this device would have been more suitable in that case, where we could have used a 30mm device and then you would have an extra low lid, which is 34, and it will shut the device off. So this is an example of this device being advantage. The other advantage of this device is rounded, so if you miscommunicate, you can actually do a partial recapture and then you can put it in. Just to tell you, the Generation 4 device, which I showed you previously, is very interesting because you can completely recapture it and then you can reposition it again. The reason why, if you completely recapture, you have to reuse a device now is because the barbs get damaged. But now with the new configuration, you can recapture, push it back again. So here's an example. You see the atrial appendage over here in the 45-degree view. That is the lobe and that's the lid completely shut off. This is the NFOS view of the appendage, and that's the complete lid shutting it off. So you can see over here, you can actually get a complete shut of the appendage. The disadvantage of this device is that if you do proximal, you may actually affect the mitral valve, which is close by, and you may actually indent the pulmonary ridge, Coumadin ridge. So these are the issues with this device. So it's not, so nothing is completely perfect, but this is the advantage of this device. So it's CE mark approval with 2008. is a European post-market registry with 143 patients of 200. The US clinical trial, which we were a part of, there were 45 patients done, 31 devices and 14 patients to medical therapy. They're starting a prospective randomized study starting at the end of this year, and they're expecting it to be a 1,000 patient study. So it's a very large study with this new device. So we hope that both of these will actually show similar results. So this is the WaveCrest device. This is the other one, which is very new. There are only about 6 or 7 cases done, actually 12 cases now, and the results seem to be very encouraging. The new thing about the WaveCrest device is covered with PTFE, which is very non-thrombogenic, and so we think that this device will be effective in people who cannot take Coumadin at all. So I'm just going to show a few words about our own experience in Cedars-Sinai. We've done about, I think, close to 85 or 68 cases. Most of my devices are related to the Watchman device, a few with the Amplatzer cover, and basically the WaveCrest is only preclinical studies. And in our data, which we actually showed in the ACC this year, we demonstrated over here that in 72 patients, we had a CHAD score of 2.4, we had 100% implantation success. 67 out of 72 patients came off Coumadin at 45 days. We had 0 periprocedural strokes. We've had 1 patient with a tamponade which had to be drawn immediately after who did well. And the cardiovascular death was 1 patient at 8 months, which is related to congestive heart failure, not to the procedure. We had, unfortunately, 1 patient at 8 months who had a small ischemic stroke. But this is the most impressive thing, that we have 72 patients over 5 years, and 90% are come off Coumadin, and yet we've only had 1 event. So just in our own experience, we're beginning to realize that this actually, the concept is correct. We've had no deaths, no tamponades, and no periprocedural strokes. And so the safety events were quite low, the efficacy results. So just from a single center experience, I feel personally that this is the right thing. So this is the FDA withdrawal. I just want to tell you that so that I can conclude by saying that percutaneous closure of the atrial appendage is an effective alternative to long-term anticoagulation. There are early safety issues, but no long-term issues. And the ongoing studies and more clinical experience will confirm this hypothesis and will improve the safety. And hopefully one day, sooner or later, we'll have this device in India. Thank you very much.
Dr. Kar, what is the incidence of displacement of this device and embolization of the device? And
yes, I apologize. I should have answered this in the... So the incidence of the Watchman device, where is the person who asked me the question? Where are you? Oh, you asked the question. Okay. The incidence of displacement of the Watchman device is less than 1%. It's actually very stable, extremely stable. The incidence of the Amplatzer cardiac plug actually is slightly higher. But the number I don't know because they haven't never published the data. But just to tell you, in my own experience, I actually had one with the even out of 8 cases. So I actually had 1, and so it came out, and then I had to put it back and then take it back again. But the Watchman device is a very, very stable device. It's very unlikely to come out.
With new novel anticoagulants available now, how do you place these devices compared to
so
new anticoagulants?
Right, with dabigatran and available with other ones. So there are certain groups of people who will not be able to tolerate even the newer drugs. So I'll give you some examples. First of all, as you know, dabigatran has a higher incidence of GI bleeding than even warfarin. And actually, 10% of patients were taken off dabigatran because of GI intolerance. So there's a group of patients there. Second is, you know, there are a lot of patients with coronary disease who are already on aspirin and Plavix. So if you now give a person aspirin, Plavix, and now dabigatran, his bleeding risk is going to be very high. So these groups there are certain groups of subsets of patients who clearly are at bleeding risks, right? And those people, probably a long-term medication is not going to be good. Finally, we say that dabigatran doesn't have to be tested, right? We don't have to test it. But this is not really correct because we know that in extremes of body weights, either too small or too large, a fixed dose may not be the right dose. Just because we don't test the level doesn't mean that it's correct for the patient. So I'm saying there are a group of patients. And then third is if a patient has had a history of a hemorrhagic stroke or a bleed, then putting in another antithrombotic drug is probably safer. This would be a better advice. So there are groups of patients clearly who will benefit from, there's a role for both these devices.
Another question. There are some indications that all the emboli may not be from the left
yes.
atrium. So so still there are chances of getting strokes after you have put in implants?
Right, of course. And that's why you see in the data that when even with warfarin data, you bring down the stroke rate from 6%, average 5 to 6% to 3%. So that means 2 to 3% are either not coming from the atrial appendage or are not effective. So it's never going to be zero, because there are many more causes of ischemic stroke rather than just this. By the way, just to give you, since you've asked this very nice question, to me this is a very sensitive point in my own life. My father, who was, most of you know, was a famous cardiologist, completely ended his career because of a stroke from atrial fibrillation. And the reason why I take this so seriously, and I took this as a passion because of that, because I just want to tell you that you guys, we are all cardiologists, we take care of heart attack patients. And we know that you can have a heart attack and walk out an angioplasty in 2 days and no one will know that anything happened to you. But an ischemic stroke is the most devastating thing that can happen to people. It changes life forever. And that's why anything that can reduce it even by 1% is beneficial.
We had discontinued these patients from warfarin. What were the criteria which was used for the same? Like, when did we decide? How can we discontinue warfarin?
So what is the criteria for taking warfarin? Okay? So the anticoagulation strategy is as follows. After you put in the device, all patients go back on Coumadin and baby aspirin, 81 milligrams. Okay? At 45 days, we do a TEE. And we look for 3 things: thrombus on the device and residual leak around and stability. If there is no, and the residual leak is considered to be anything greater than 5 millimeters on either side of the device in multiple views, right? You remember those views? And if you have less than 5 millimeters and you have no thrombus in the device, Coumadin is discontinued at that point. And then you have an overlap of about aspirin and Plavix for 6 months. And the reason for that is we know that devices take about 3 months to completely endothelize. And then at 6 months, if it looks the same, then they come off Plavix and then they stay on aspirin. So basically is TEE. So realistically what we do now and we recommend is do 45 days, and if it looks good at 45 days, don't repeat the TEE at 6 months, just do one at 1 year, and that's it. So it's TEE guided.
Yes.
Right.
Dr. Somaraju?
While we oversimplify the anticoagulation following a device occlusion, does the LV function, does the LA size, do they have a role?
Yes. So you're saying about, talking about ejection fraction, patients with low ejection fraction? Yes, yeah, right. So this is a good point, that the CHAD score itself is a very simple method, but it's probably not right. You can have a CHAD score of 1, but have low ejection fractions or very large left atrial appendage, atrium, and actually be at high risk of stroke. Is that what your point? And the device should be placed? We have a cutoff that if you're in the study, if your ejection fraction was less than 30%, then we didn't put in a device. But once it gets approved, you can do whatever you want. But I think that's what the cutoff is. We just didn't want to take patients with very low ejection fractions.
Sorry, I was not asking about the device indication. I was asking about the discontinuation of anticoagulation.
Oh, discontinuation of anticoagulation. Yes, even if you, see, we don't put in a device if you have a lot of smoke in the atrial. If you have a lot of smoke in the atrium, or if you had clots, then this device would never even be placed. So when we look at these patients, we follow them up, if the ejection fraction is 30% or more, there's no dense smoke in the atrium, then it's okay to come off. And we've not had an issue. Is that what you would try to answer?
Dr. Siabal, how many patients were with coronary artery disease and post-CABG?
I don't know the number, but in CAD it's about 30% of coronary disease. So the reason why that's important is, and if it's with CABG, it's even better because then they won't have a tamponade. So we like patients who have coronary artery disease with bypass surgery. But it's important that a lot of patients with coronary artery disease are present in the study, and many of them have had PCIs. And they have had, now this is a very important issue. This was actually underestimated in the study because in the study, we excluded patients who are on aspirin and Plavix, right? So we actually lost that benefit. If we had those patients in the study, we actually may have shown a greater benefit because the bleeding risk would have been higher in that group of patients in medical arm. Because what you saw in the medical arm was when you followed these patients, there were 6 hemorrhagic strokes over 5 years in the control arm, only 1 in the device arm. And what do you think happened to the 6 with hemorrhagic strokes? 5 died. And that's why I always ask people, what do you prefer, a pericardial tamponade or a hemorrhagic stroke, and die from it? And you can choose that. So it does, but that's the point. If we had chosen patients with aspirin and Plavix and CAD, we may actually have shown a greater benefit, but we couldn't do that in the study.
The patients who are going for CABG, I think LA appendage should be removed in those cases.
As in the American College of Cardiology has a recommendation of exclusion of atrial appendage for valve disease. The recommendation is that for valve disease, if you're doing an atrial, you should, with AFib, you should exclude the appendage, right? But for CABG, I don't know, but you're right, probably.
But later on,
Right.